Lovely to be here again. This lecture, when I saved it, it was saved as Anuradhapura 2025. That means I've been here for a while and I don't want to mix my lectures. When I'm going back, 2024, everything is in the computer. Today, my task is to give you some sort of insight into what sort of ONG awareness you should have when you are practicing in whatever the speciality. It's a bit of a simple presentation. Yes, like many physiological functions in the body, we have the hypothalamus which controls the anterior pituitary and then the ovaries. So basically, just a reminder of what you learnt in the medical school. And estrogen and progesterone, absolutely necessary for this function to go on. I need both hands for this. Pointer in one hand and the other one. Right, here we go. Then, of course, there are other endocrine organs which will help that mechanism. Thyroid and adrenal are important in that. This is the cycle which you may have studied in the medical school again. The important point to remember is that this estrogen level, you can see it here. If the estrogen levels are low, the endometrium is thin, and when the estrogen levels go up, it becomes thicker. And once the progesterone comes into the picture, it becomes even more thicker. Why is this important to understand? To understand the clinical problems, we have to understand these basics. If there is progesterone, this does not break down. This endometrium doesn't break down, so there will be enough progesterone after ovulation. Ovulation is releasing an egg, which happens every month. And then, if there's enough estrogen, again, the endometrium will not break down. A little bit of anatomy. This is how the uterus forms. It comes from the urogenital ridge and has two tubes which fuse in the middle, and then finally there's a resorption of the septum, and then you get a cavity. So you can understand that if there's any issue here, rather than having this structure, which is the normal uterus, the body of the uterus, fallopian tubes, ovaries, and the vagina here, you can have any of these abnormalities, and that becomes, that this knowledge is important for you to understand some of the issues, clinical issues which you may be seeing, whatever the practice you are doing. Again, it's important to understand that the kidneys and the gonads, they all form together from the same ridge. So if one is having problems, the other also can have. So if there are uterine abnormalities, you can have renal abnormalities and vice versa. The other one is the relationship of the uterus to the rest of the viscera. Why is it important to understand? Because they can share clinical features or clinical symptoms. For example, appendix is here, cecum is here, and the right ovary and the tube are here. So they can mimic each other's clinical problems, or they can be involved with each other in presenting. Similarly, on the left side, you've got the sigmoid, and behind the uterus there's a rectum, and the left ovary and the left tube can have issues which can be sometimes mistaken as problems of the bowel, or again vice versa. Bladder in front, again you can have sharing here. And there's another important point there. That's the uterus, that's the bladder, that's the pouch of Douglas, and this is the rectum. So whatever happens in these areas can affect the organs next to each other. For example, if there's something here, this uterus could go and get stuck onto the rectum here. Or similarly, if somebody has operated on the uterus, then there could be adhesions to the bladder here. This is how we would see it inside. You can see here, sigmoid coming and becoming the rectum here, and then the tubes and the ovaries. One other particularly important point for everybody to understand is this area which I have demarcated with the blue line, this area is estrogen dependent. Even though the bladder is here, bladder is also estrogen dependent. Bladder lining, the transitional epithelium, the health of the epithelium, thickness, everything is dependent on estrogen. So there will be repercussions later which we can discuss. Then Ovulation occurs every month, I told you. This is the mechanism. A group of follicles get recruited and then one of them gets released around the day 14 days before the next period. So depending on the duration of the cycle, the day of ovulation can change. And this is the picture of different stages of that follicle. And as you can understand, when this happens, there will be some sort of symptoms in some people because there is stretching of the peritoneum going on here. This is after the ovulation occurs and corpus luteum forms, and there will be some sort of fluid here which also can cause some symptoms. This is another common issue. Now we are coming to the actual theme of our subject today. What sort of awareness you should have about ONG issues when you are dealing with any general patient, irrespective of what they have come for. This is one of the commonest things. On ultrasound reports, you may see every now and then 3 centimeter cyst in one of the ovaries. And this is the commonest 3 centimeter cyst you will see. It's a follicle. And if you are not aware of that, if you don't relate the ultrasound to the menstrual cycle of the woman, and if she is in the reproductive age, then always think about the follicle before thinking about a cyst, because otherwise we will be operating unnecessarily. Because I have just shown you that, and it can be seen like this. So if you are not aware of that, you might label this as a cyst. So some common presentations I thought I'll discuss with you, because if you are in an OPD or in an emergency surgical ward, medical ward, any ward, you can have some of these issues. Now, there's a thing called dysmenorrhea. Dysmenorrhea is painful menstruation. A common problem to a lot of women, particularly younger people. What you have to remember is severe pain during menstruation is associated with ovulation. It is in fact a clinical feature of ovulation. To find out whether a woman is ovulating, we have to ask whether her periods are painful. When a child is young, in the first 1 to 2 years after menarche, they don't have painful periods sometimes because they don't ovulate. So these are points you have to remember. If a young girl comes to you, surgical wards particularly important, with severe pain on one side of the abdomen, which increases during periods, but remains sometimes even after that, you have to think about the picture I showed you, where the uterus was being formed. One of the tubes may be not attached to the other side of the tube, and the blood will collect here, and there will be severe pain and a mass on one side of the pelvis. Again, ultrasound might say there's a cystic mass. And if you operate hoping to see a cyst, there may be a uterine abnormality. That is why we generally recommend that you do MRI before embarking on major surgical plans for young people. There's a thing called secondary dysmenorrhea. That is the women who did not have severe pain during their periods start developing that towards the latter part of their life, in reproductive life. One of the commonest these days is this condition called adenomyosis. If any injury occurs to the uterus, whether it could be a scraping of the endometrium, which is called evacuation of retained products, or DNC, DNE, you may have heard about that, or cesarean section or myomectomy, any injury, this endometrium can get deposited in the myometrium. So what happens? Every period, when the menstruation begins, there's bleeding from the vagina, but there's bleeding into the myometrium as well. That blood has no place to go, so there's excruciating pain, severe pain, much worse than the normal dysmenorrhea they have. So you have to think about that. Again, very important to get the history, because if you have missed the history of trauma to the uterus, then you will miss the diagnosis. So during this period, let's say here the periods begins, pain begins. Here the menstruation stops, and the pain will be there a little more than the duration of the bleeding, because there is pain here due to the acute inflammation which occurs due to the bleeding. Next one is, of course, pelvic endometriosis, where the uterine lining or the endometrium lies on various places. Depending on the place, if it is in the brain, you'll get epilepsy. If it is in the nose, you'll get epistaxis. If it is in the lungs, they will cough out blood. If it is in the knees, they will have hemarthrosis during periods, but those are extremely rare, and the commonest one is on the ovaries. So you can have little dots here, old blood. Initially, it causes pain only during periods. But this bleeding begins before the vaginal bleeding actually shows up, because there will be ischemia in this area. Endometrium gets ischemic before bleeding, breaking down. So you will have pain preceding the bleeding. So these are the features you have to ask. If you don't ask these things, you cannot diagnose. These are not scan diagnoses. I personally don't believe diagnosing through scans. You have to give the hints to the people for them to go and look for those things. So preceding the menstruation and outlasting the menstruation. Initially it will be like this. And if you ask the story correctly, the patient might say towards the latter part, no, I now have pain even after the periods. Why is that? Because this collected blood will form into a permanent collection which is called a chocolate cyst. You must have heard this word. And if this endometrium is in the pouch of Douglas, which is the commonest place, because the ovaries are posterior to the uterus, and on the ovaries there's endometrium, that endometrium causes endometriosis. And if there's during intercourse, there will be pain here. That's called deep dyspareunia. I'm sure you're not used to asking these questions, but you must ask, because these give you extremely good clinical clues. No scan will tell you this. Then I'll go into some other very important clinical presentations you meet. I have actually listed this because of the time constraints. The life-saving things first. So, without fever, I have mentioned that without fever. Now you have to remember this picture when you are thinking about these conditions. One of the most important things to diagnose abdominal pain, whether it is surgical, medical, whatever, is to ask the patient to point one finger to the worst place of pain. We don't do that. Many times we say abdominal pain. No. Abdomen has various areas which give you different types of pains. So this anatomy has to be remembered, and whenever they point, we know what are the structures we have to be thinking about. Without this, we cannot make diagnosis. So my messages today are mostly clinical messages, not high-tech. So what is the differential diagnosis? If somebody says, I had severe pain, ectopic comes right at the top. If it is on the right side, appendix has to be suspected. Twisted ovarian cyst, ruptured ovarian cyst, or colic either from ureter or bowel. You saw the anatomy, so those structures are there. So any one of those can cause this. But one of the most important things to understand is, for a woman to have ectopic, they don't have to have a period of amenorrhea. In other words, before missing a period, they can have an ectopic, depending on the site of the ectopic. So you can have a beta-HCG being positive here, even though the next period was supposed to come here. Remember that. So don't rule out just because a woman hasn't had a period of amenorrhea. And also, let me go back. Don't go on urine HCG if you want to diagnose an ectopic. Ectopic is a killer, and you cannot miss it because the urine sample did not show a positive test. So always go for beta-HCG. It's available. And initially it can cause discomfort, it can cause a leak, or it can cause a rupture. If it's a leak, that means a slow leaking ectopic. It causes permanent pain in the abdomen, but not very acute. But sometimes it can rupture. It could happen during sexual intercourse, as I showed you here. If the ectopic is here, that pressure can do that. And remember, vaginal examinations can cause that. And that's why we tell that if the story is clear-cut about ectopic, don't do vaginal examinations. You cannot get any additional information by doing that, but you might actually rupture the ectopic. And also the transvaginal scan probe can do that. So you have to be very conscious about these things. We have seen patients being wheeled directly from radiology rooms or even after examination to the theatre because they can bleed very heavily. They can get a vasovagal syncope. But the important thing to ask the patient, when did you actually get this pain? It is amazing to see that patients can remember. They will say it was about 20 minutes after the meal, I was watching television and suddenly I felt the pain. That immediately gives you a clue. It's an accident, and what is the structure which can have accident like that? Not the appendix. Not the appendix. There's no point groping around. So the other point here is there will be pain and there will be bleeding some hours or days later. Why is that? I told you that there will be production of estrogen and progesterone. Pregnancy also produces that because the corpus luteum produces and then this ectopic starts producing that. So what happens when the ectopic dies? Here there won't be any bleeding. Once the ectopic ruptures, the function goes down. Then the estrogen and progesterone levels go down. Then the endometrium starts breaking. So you have to remember this sequence. In an ectopic, you will never get bleeding along with the pain, always later. In contrast to the differential diagnosis of miscarriage, where bleeding is followed by or along with the pain, either together or comes later. So that is because there will be threatened miscarriage initially, which will be painless, and thereafter only the pain starts coming. So that is the way we differentiate the ectopic and incomplete miscarriage, and also the way the patient lies. Because when the blood tracks under the diaphragm, patient naturally adopts this stance, or they sit on the bed. They will never lie flat because they get chest pain and they get shoulder pain. So initially the pain will be here, but when it comes to this stage, the pain can go up and up right here. So you can have pain all over the abdomen with an ectopic. Next dangerous one is the twisted ovarian cyst. There will be a stalk and a cyst. Why is it important? It is important, twisting. I want to show you that there will be twisting and untwisting. So the best example I thought was this, because most of you must have seen people trying to pluck coconuts. As medical students, we used to do that in the next door compounds. So unless you hold on, it untwists. So that is what happens to the ovarian cyst also. They twist, they get a pain, and they untwist. So if you ask for the story, usually they say, yes, I had this alternating pain and disappearance of the pain, and then now I am having continuously the pain. What happens after that? After that, it twists. Twists like this, once, twice, maybe. And you can see here the ovary getting involved in this. It's like a torsion of the testes. Very painful, continuous pain. Not like miscarriage where intermittent pain comes. And also, remember why we have to attend to this, because the fallopian tube and the ovary can get dragged into this twist and they can actually die. They can get necrosed, because it usually happens in children and young women. So we can't sacrifice their ovaries and tubes. So if this goes from surgical ward to the medical ward to the surgical ward to the ultrasound, all that, if you have missed the clinical diagnosis, they will lose the ovary. So this is the story, and once the transitive date from this comes, the pain which was here can start going up. Ultimately, the pain actually goes down because after ischemia, the ovary becomes dead. Completely the cyst becomes necrosed. So if we wait for this, there won't be any respite. Even if we operate, that ovary will be gone. So these are some of the conditions which I am showing you. Sometimes a chocolate cyst can rupture. That is an endometriotic cyst. And it will spread all over the abdomen, under the diaphragm, everywhere. And there will be uniform pain, severe pain sometimes. Fever. When fever comes into the abdominal pain, some of the conditions which I mentioned earlier also can give mild pain. But appendicitis is well known, pelvic inflammatory disease. Chocolate cysts can get infected. That can cause pain. And cystitis can cause pain, and also combinations of these. But remember that. Pelvic inflammatory disease is where a bug will go up and go up here. There is no restriction to go to the left or to the right, and most of the time they go to both. And symptoms may be more on one side than the other. This is the sequence: cervix, endometrium, tubes, ovaries, masses, and the peritonitis. That is the sequence. This is how it looks initially. There will be fluid in the pelvis, and later there will be pus in the pelvis. This also can get infected. This also can cause fever when there is necrosis, but not high fever, like in pelvic inflammatory disease. This is what is called red degeneration of fibroid. That also can cause a little bit of fever. This is due to hemorrhage and necrosis of a fibroid. The clue to the diagnosis is, if the woman is having multiple fibroids, she will be able to pinpoint to the particular fibroid which is having degeneration. And when you are palpating also, you will feel tenderness only on that particular fibroid. These are important clinical clues. Our hands have been trained to do these examinations, not like sending them to the ultrasound and the radiologist trying to tell you what is the diagnosis. No, most of the time those diagnoses can go haywire if you have not really followed it with your clinical judgment. So, chronic lower abdominal pain, that's the next one I have lined up. Endometriosis can cause that. There are a lot of adhesions you can see. All these adhesions are like, if you ask them what is the pain like, it's like a bad tooth, you know. They are niggling. All the time the pain is there. Not very severe, but it's there. And sometimes they say abdominal discomfort and flatulence. I want to highlight this particular point because adhesions can cause these problems. But even intestinal adhesions hanging on to the anterior abdominal wall after previous surgery, all these can cause problems. A tube getting swollen can cause, that is called hydrosalpinx. Diverticulitis can cause similar thing. I showed you right at the beginning. Now you can understand why I showed you the anatomy, because it's the same area. So but whatever you think, don't miss ovarian carcinoma. That is the message. That's the most important message I am going into today. Vague abdominal pain is not gastritis. It is ovarian carcinoma in women, particularly middle age and after that, until proven otherwise. So please remember that. Don't disregard chronic discomfort in the abdomen, saying that it's a psychological issue or something like that. So, recurrent cystitis and urgency, rushing to the toilet to pass urine. I don't have to explain to you, particularly after menopause. Because of the estrogen inadequacy, you can get urgency here, and also there's a high propensity for infection to develop in the bladder. Because I'm coming towards the end of the lecture, I don't think I'm going further than this. I have lined up some menstrual issues, but the only thing I am going to show you here is this type of menstrual bleeding, where irregular, no pattern, every now and then a little bleed. Always remember carcinoma, either in the cervix or in the body of the uterus, because they can kill. So these are the killers I want to mention to you within this half an hour. Even if the woman has got a polyp in the cervix, that is not the diagnosis until we have ruled out this. So Kumara, I think the half an hour has come. I'll leave the lecture. There's a little more than that, but that's quite okay. So thank you very much for inviting me.